My name is Amanda Ganatic and I'm a student at Arizona State University. I put this presentation together to talk about how opioid use has increased in the United States and how important it is to have a countrywide program to monitor when prescriptions are written and how they are being filled. I want to start my presentation by sharing a brief story with you guys. About 2 years ago, I was working for an agency in Tucson, Arizona that dealt with clients of mental and behavioral status and also existing diagnosis of substance abuse disorder. We had a location at our agency that distributed methadone and Suboxone to help patients with drug addiction to stop using. And as part of our requirement of working there, we had to attend 2 conferences every month to continue education and keep us up to date with new medications and new ways of helping our clients. As we were sitting down, we began to talk to our lecturer, who told us that she had recently been in a car accident and went to the hospital to get checked out. She had told the doctor that she was only having minor pain in her muscles from being rear-ended, but her prescriber had suggested that she start taking some pain pills. Her prescriber gave her prescription for hydrocodone, which is an opioid, and she told us she was astonished that just complaints of minor pain would set her on the path to possibly developing an addiction. Another attendee of the lecture added that they had clients that would purposely pull out their own teeth in order to go to the dentist and be prescribed more pain pills. The last story that we were shared was a tech who stated that she would see patients go into methadone and Suboxone clinics, and they would take their dosage within the clinic and they would walk outside and someone would pay them and they would give their dose to another drug addict. At this point, it was clear that drug addiction was getting out of hand and prescribers were overusing their abilities to prescribe pain medications. Therefore, I did a little research on how bad the problem of opioids has become and recommendations that doctors, prescribers, and the country can use to be more vigilant with the use of opioids. First, I'm going to start by giving a description of the problem with opioid prescriptions increasing, and then we will move on to who is being impacted by this problem. After that, we will begin to take a look at the scope of the problem and how large it is in the United States, and the range of the people it affects in the U.S. We will also look at some of the key causes of the problem and a brief history of the problem. Next, we will also take a look at the consequences, both large and small, of not addressing the problem. And last, during our presentation, we will look at current approaches and critique their effectiveness, followed by my recommendations for assisting with decreasing opioid use. Pain is a problem in the United States that has gone untreated by pain specialists. 19% of U.S. adults reported having chronic pain, while 34% of adults reported recurring pain. From those experiencing pain, it was found that only 63% had reported this pain to their doctor in an attempt to decrease the pain. This pain may stem from arthritis, cancer, muscle pain, or other undiagnosed conditions. As these conditions worsen and patients report their pain is still increasing, in an effort to give their patients relief, physicians have attempted to treat the pain more aggressively by prescribing opioid pain medications. Over the last 25 years, the rate of opioids being prescribed has been rising. Hydrocodone prescriptions have increased by at least 60% in a 4-year period, oxycodone by at least 50% in the 4-year period, and fentanyl by 150% in a 3-year period. Doctors in the medical industry have changed the way in which they treat the topic of pain, as recently the treatment of pain has switched from using short-acting medications to long-acting formulas such as hydrocodone and heavier pain medications to treat chronic pain. Physicians also do use hydrocodone, which is a short-acting opioid, in order to give patients immediate relief for acute pain. Hydrocodone is easier for physicians to prescribe, as under federal law they can write a prescription that can be refilled 5 times in a 6-month period. With each rise in the number of prescriptions written, there is a greater chance of patients developing an addiction to opioids. The current research has estimated that approximately 2.1 million people in the United States are addicted to opioid pain relievers. There has also been a quadruple increase in the number of deaths from an overdose on prescription pain pills since 1998. Previously, opioids had been prescribed to those with chronic pain, while now they are being prescribed and affecting groups of people with non-malignant pain as well. Opioid prescription drug use has even increased in rate compared to street drugs. In 2002, there were 5,528 deaths from opioid poisoning, which was more than either heroin or cocaine. There has been a decrease in street drugs used by the youth population, while abuse of prescription pain medication has continued to rise. In 2005, 9.5% of kids in 12th grade reported they had taken hydrocodone. Recently, while working at the Behavioral Health Hospital in Scottsdale, Arizona, we were holding morning group when one of our new admits to the hospital decided to tell his story of how he got admitted. The 17-year-old boy admitted he had an addiction to pain pills and had been using them for the last 3 years. The boy stated he tried to stop on his own, but the pain caused by withdrawals quickly returned him to using the pills again. The boy wanted to go to college, but instead had been spending weeks at a time inpatient at various hospitals trying to detox from opioids. Let's take a look at the history of opioid use and how it's changed recently. Increasing prescriptions of opioids has significantly been a problem for the last 25 years. The number of prescriptions for heavy pain pills such as hydrocodone and oxycodone have increased from 76 million prescriptions in 1991 to 207 million prescriptions written in 2013. There has also been an increase in the rate of hospital visits due to opioid emergencies, from 144,600 visits in 2004 to 305,900 visits in 2008. Research has also shown that the number of deaths from opioids has increased by approximately 85% from the years 1999 to 2006. As the need for pain medication rises, there has also been an increase in the number of medications being stolen. In 2003, it was found that 2 million doses of medications such as methadone, fentanyl, and oxycodone were reported stolen, while in 2003 it was reported that 4 million doses of hydrocodone were stolen from the supply chain. Let's take a look at this bar graph so that we can get a visual representation of how opioids have changed. This graph on the horizontal axis shows the years from 1991 to 2013, while on the vertical axis shows the number of prescriptions written measured in millions. The red line running through the middle represents the number of hydrocodone prescriptions that have been written, and the green line towards the bottom shows the number of oxycodone prescriptions. The blue bars show the other opioids that have been prescribed to patients over the years. As you can see, in 1991, we started with 76 million, while by 2013, we're up to 207 million prescriptions being written. That's a huge increase of opioids being misprescribed, misused, and we'll continue looking at ways that we can combat that problem. Now we'll take a look at who's being impacted by this problem. The problem of opioid prescriptions increasing can lead to an opioid addiction. Opioid addictions can affect anyone who goes into the doctor's office experiencing pain. It may be a toothache or broken bone, but the chance of being prescribed an opioid is increasing. Opioid addiction affects men greater than women in the age range 45 to 54 greater than young adults. Opioid addiction is also higher in whites and Native Americans compared to African Americans. Patients with a genetic predisposition in the mu-opioid receptor are at greater risk of developing an addiction once they are prescribed an opioid. Once developing an opioid addiction, the relationship between the patient who is addicted and their family, friends, and workplace are often affected due to the patient trying to cover up their addiction and becoming withdrawn from their peers. The increase in prescriptions also affects doctors and psychologists, as patients will most likely keep returning to seek medical treatment for their untreated pain. Lastly, health insurance companies deal with the financial aspect of paying to cover someone who is addicted to opioids. There is a huge impact on healthcare companies due to this increasing rate of opioid abuse. Currently, the costs are 8 times higher for opioid abusers versus non-abusers. This rising cost comes from the fact that opioid abusers are more likely to have long-term hospitalization as well as emergency room visits compared to a non-opioid user. The average healthcare cost per person for opioid abusers are $15,844, while a non-abuser only costs $1,830. Currently, there are very few healthcare companies that prescribe long-acting opioids as opposed to the immediate-release opioids. In order to decrease the high cost, providers would have to prescribe long-acting opioids, as the long-acting opioids reduce the cost of the healthcare system. There has been funding provided for programs that track prescription drug use from the Bureau of Justice on a state-to-state basis. This funding implements programs in 33 states, and this funding tracks the rate prescriptions are being written and can provide data on how to reduce costs to the healthcare companies. One key cause of the problem is that there is a huge lack of communication between the doctors, nurses, and patients when communicating the severity of the pain that the patient is indeed feeling. Patients can easily state they are feeling a severe amount of pain if they know the doctor is more likely to prescribe them a heavier pain medication. Patients who have developed addiction also take part in a thing called doctor shopping. Doctor shopping allows patients to obtain a prescription from multiple practitioners for the same medication at the same time and allows them to have a daily dose of the opioid as opposed to a recommended amount by the physician. Data on the rates at which patients doctor shop or falsify their identity to obtain opioids is limited due to the fact that individual states have no way of tracking when this is happening. It is recommended that all practitioners screen their patients for family and past history of substance abuse before prescribing a medication. Now we'll take a look at the consequences of not addressing the opioid increase. There are numerous dangerous short-term and long-term effects from using opioid pain medications. Some short-term effects people can experience include dizziness, vomiting, and respiratory depression from abusing opioids. Long-term opioid abuse can lead the abuser's bodies to developing an addiction to using prescription pills to relieve pain. Some effects of this long-term addiction can lead to less tolerance to pain, changes in their overall brain functioning, decrease in their commitment to relationships with friends, significant others, and even employers. The other consequence of not addressing this problem includes an increased rate of people dying from accidental overdose on opioids. Evidence shows that there has been a 137% increase in deaths since 2000, as well as an increase in cost to healthcare companies as a result of their overuse of medical treatment. Currently, it appears that many of the programs in place for the problem of rising opioid addictions are happening after a patient already becomes addicted. Once the addiction has begun, the programs then provide methadone or naltrexone or Suboxone to help limit the patient's use of opioid prescription drugs. Other programs have been aimed to combat the psychosocial aspect of addiction and to help patients with therapy and psychological interventions to help treat their addiction. In order to be successful, the few programs aimed at monitoring prescription use need to become more widespread and vigilant in tracking prescriptions written versus being filled, as well as monitoring patients' pain levels over time in order to redirect the patients to pain specialists. By preventing the addiction from occurring, we can target the initial problem instead of trying to combat its effects. My recommendation in order to decrease the use of opioids would be to add a mandated countrywide policy that tracks the date a patient is prescribed a medication, when and where they fill the prescription, and how often they fill the prescription. If this is countrywide, then any dentist, doctor, hospital would have access to these records to make sure that patients are not being overprescribed. We'll take a look at Ohio. Ohio is an example of one of the states that have attempted to decrease the rate of opioids being prescribed to patients with a monitoring program. The program is in place in order to attempt to support the medical use of controlled substances and limit the use of opioids for drug abuse and diversion. Their program was implemented and results showed that access to records of prescriptions changed the behavior of practitioners and their likeliness to prescribe an opioid in 41% of their interactions. In approximately 61% of the cases, they saw a decrease in the number of opioids being prescribed. This Ohio program exemplifies the increase in responsibility of practitioners when prescribing opioid medications. A nationwide program with a combined effort could provide a large decrease in opioid abuse. We'll also take a look here at Washington, as Washington is one of the other states that have put programs in place to combat opioid abuse. In Washington, programs have been implemented that if a patient reaches a daily dose greater than 120 milligrams, then they are recommended to obtain consultation about a possible addiction. There have also been surveys handed to providers regarding the Washington AMDG opioid dosing guidelines, and results found that only 45% of those providers were aware of this program. Therefore, the providers in Washington are lacking education about when they should be prescribing opioids and the strength of the medication. If this is happening in Washington, it's very possible that without tracking, it could be happening in other states as well. Washington has also recently implemented another program that tracks the pain level and functional status of patients who come into the doctor's office to be treated for chronic pain. The policy states that each visit, patients will fill out a questionnaire on their daily pain level, quality of life, and previous mental illness or substance abuse. The hope from receiving these questionnaires is that practitioners will shift from using pain pills to using exercise or behavior modification techniques to treat chronic pain. Although the law is not fully in place due to a limited number of pain specialists to meet the demand, Washington hopes that when the law is in place, it will provide measurable results of the policies aimed at decreasing opioid abuse. With a nationwide program, policies and guidelines for doses and strengths of medication could be mandated, strictly followed, and reduce the amount of addictions from overprescribing opioids. Currently, each of the drug monitoring programs are designed and run by each state individually. Federal funds have been distributed by the Bureau of Justice in order to help collect data between each state and exchange the data appropriately. The Bureau of Justice has also assisted in creating and expanding various data collection and systems of analyzing drug use. These programs are limited currently due to the differences in data collection systems between states and how to appropriately exchange information between the states. Majority of states have programs in place to track the rate at which prescriptions are being written, but they are limited on the type of data they collect. Having a single, more efficient method of collecting data on patients' backgrounds with substance use, when patients are prescribed a medication, what dose they are prescribed, and how often they are filling the prescription for medication would help physicians and pharmacists detect when abuse is beginning to occur. The problem of opioid abuse has been increasing rapidly over the past 25 years, and in some years the rates of prescription opioid use has been higher than the use of street drugs. Prescribers need to be more vigilant in monitoring their patient's family history of abuse, the patient's current opioid use practices, and the amount and strength of the prescription. There are currently programs in place to help patients who are addicted to opioids, but limited methods to prevent the addiction from beginning. The drug monitoring programs are limited by the feasibility of implementing, the cost of implementing, the burden on the healthcare system, the negative consequences of treating pain appropriately, and the impact of abuse. The current funding in place in majority of states to monitor abuse needs to be redesigned in order to be effective. With proper communication and cooperation between the government and all of the United States, the funding could be reallocated into a single program which could track prescriptions and patient use. The best and most effective methods from each of the 33 state programs could be utilized to create a single nationwide program that would be most effective at monitoring and preventing the beginning of opioid abuse.